Good afternoon, everyone, and good morning to some of you who might be joining us from North America. My name is Farid Talia. I am a psychiatrist at AUBMC. I'm an associate professor of psychiatry. It is my pleasure to be participating as a moderator, and I look forward to listening to what Dr. Bizri is going to share with us. It's my pleasure to introduce Dr. Bizri. Dr. Maya Bizri is an assistant professor of psychiatry at the American University of Beirut. She graduated from AUB Medical School, and then she also completed a master's in public health from in the US at Tufts University. And after completing her MPH, she returned to Lebanon, where she joined our psychiatry. Actually, it was a quite brand new psychiatry residency training program. She's one of our earliest graduates from the program, and she completed her training at UBMC at the psychiatry program, and where she was an excellent trainee. And then she went on to further advanced training, and she was accepted at the Cleveland Clinic in Ohio to do a fellowship in psychosomatic medicine and consultation liaison CL psychiatry, which involves working with complex neuropsychiatric and medical patients who are usually in a tertiary hospital setting, where they present with a complex picture with multiple comorbidities. She is also, since joining us now, it's been more than 2 years. She returned again to Lebanon, and she is the director of the CL services. So we did not have CL services, consultation liaison services at AUB. So she organized the service where she leads a team of psychologists, as well as trainees, residents, and medical students who established a very busy CL service at the hospital, which interacts with all departments from emergency room setting to the ICU setting. And she specializes in delirium management and psychosomatics. She also works closely and became director of the psycho-oncology program, which in partnership with the NKBCI is launching multiple initiatives from patient care to research. And this service is very badly needed in Lebanon, where there is a very minimal of psychosocial services provided to cancer patients. And she also is involved in multiple research projects, quality enhancement projects, and is instrumental in our teaching and education of residents and students. So it's my great pleasure to hand over the floor to Dr. Bizri, who will talk to us about the impact of COVID on psychiatry in general, and how we try to innovate and think out of the box to deliver psychiatric care in this pandemic.
Thank you, Dr. Talia, for the introduction. Dr. Talia is a mentor. He is actually, I don't know if you remember this, Dr. Talia, but he's the one who suggested I go into CL psychiatry. And thank you for inviting us to present on our tiny but mighty service. And as the title mentions, and as so many other services in the hospital, we've had to rethink the way we provide care during COVID times. We've had to get a bit creative, think outside the box. And I'll describe, if you want to go to the next slide, Habiba, I'll describe how we had to, I have no conflict of interest, obviously, other than the fact that I work in this institution. So I'll describe how we had to get creative on many aspects, including our service workflow, responding to new clinical presentations, so that were less commonly seen pre-COVID, on how we've had to really liaise on at a more institutional level than usual, so not just interdepartmentally, and how as an academic center, which is the interesting twist here, we've had also to get creative in terms of training and in terms of research implications during the pandemic. So next slide, please. Okay, so before the pandemic, the CL service had just been restructured in 2019. It's not that it wasn't there before, it just got restructured. It started including the full-time psychiatrist, the resident, medical students, and the health psychologist upon request, or a psychologist that really caters to the medically ill. And these were covering medical, surgical units, critical care units, and emergency consults. We had a rule of the same day, and I think this is important to present. So before the pandemic, we had a rule of either same day or next day in-person staffing. We never had curbside. We have a curbside, meaning over the phone or unofficial consults. We never had telepsychiatry consults. And we also had a rule of never blocking the consult. And importantly, for the ED consults, we had a 1 hour limit of staffing. So, and that really changed the way we were perceived at the institutional level as a responsive service. Next. And then COVID-19 came, and it was really a game changer because it was more of a disaster psychiatry, meaning the many implications, so usually in psychiatry, the way we respond to infectious disease is we usually respond to more insidious, slowly progressing infectious epidemics, such as the HIV/AIDS epidemic. We have time to develop the research for it, to prepare for it, to prepare contagion measures, restrictive measures. Whereas with COVID, it was more of a disaster psychiatry emergency planning. Just to give a bit of context, in Lebanon, the COVID hit in March 2020. There was a worsening economic inflation, political conflicts, unfolding worsening numbers of COVID. And then on August 4th, there was an actual disaster, which is the blast. And the second wave came right after that. So it strained on a healthcare system that was already working at full capacity. Remember, with this pandemic, it's a game changer because there's a significant exposure risk for populations and for the providers themselves, including mental health providers. There are social disruption. There's a sense of insecurity that is prevalent due to the measures imposed after globally there has been a failure to contain the pandemic. And particularly in Lebanon, we had to really think about allocations of PPE and medication shortages because we were running on a low number to start with. Next, please. So so in parallel to the many changes that occurred hospital-wise, we reorganized our CL service. In the early days of the pandemic, so during the first wave, our department leadership created the COVID-19 Mental Health Task Force to sort of preempt all issues that would arise, including serving to the COVID-19 patient population, but also to the healthcare workers. So we had two separate teams within the task force. One was catering to the healthcare workers at AUBMC, and one was targeting the COVID-19 populations. And early on in Lebanon, the numbers were really lower than we had thought they would be. Back then, we implemented a proactive or preemptive workflow. So all COVID-19 patients that came in to our COVID clinic, we set up a COVID clinic in the hospital. That was an entire building. And all patients that presented and that screened positive for COVID were screened for psychological distress using the PH24, which is a validated tool in Arabic. And they would have then, we would triage them all, and they would have available free of charge mental health services, whether they were admitted to the hospital or quarantined at home. This included daily check-ins, if they agreed, obviously. It also included daily check-ins on the families of those that were admitted. So it was really a 360 degrees provision of care, and it was really a very nice collaboration between us, the team, the family medicine team, psychologists, but also residents were heavily involved. They were the ones doing the triaging. And then the second bigger wave happened, and that was after the blast. And we could not obviously accommodate for everyone. So we had to switch to a more reactive or responsive traditional model of consultation, where we would wait for consults to come in. So because we could not screen everyone, and we did not have the human resources to screen for everyone. So the premise was that we still wanted to be available to our frontline colleagues for any psychiatric questions that they might have while providing optimal patient care. So we did not want to sound like we were not, like we were backing off. So our department, what we did is we circulated protocols or guidelines among department heads for the medical management of common, which we had never done before, of common psychiatric conditions arising on COVID-19 patients. So we had this quick tip sheet, and for medical management, so that someone, let's say an ER physician who has 8 patients and one of them is delirious and agitated, would go and see how to, instead of calling psychiatry to come in and check in on them, would see on the checklist what the next step or the best medication to give. And so we also included management of substance withdrawal, anxiety, different forms of anxiety. So anxiety with or without insomnia, anxiety in the setting of delirium, anxiety with depressive symptoms, and the medications differed. They've also included guidelines for delirium and agitation in non-critical care settings. I think in consultation liaison, it's always, in NCL, it's always tricky to sound collaborative without overstepping on other people's expertise. And so delirium is interdepartment, is a trans-specialty presentation. And so we decided to stick to non-critical care settings where critical, because it's more of a turf thing with critical care colleagues dealing with delirium in monitored settings. And we adapted them to published international best practices. I have to say that our go-to reference were a very active group of psychiatrists on the ACLP website. They had an open forum. They had, we could ask questions openly. They would reply to us immediately. We had circulated resources. And it was really there was not one right thing to do when COVID started. So everyone was sharing their own experiences in the US. The ACLP is the Academy of Consultation Liaison Psychiatry in the US. Importantly, when I say dynamic, these took into account the evolving polypharmacy on COVID patients. So it was more of a continuously changing protocol because we did not know much about COVID when it first started. Next, please. So within the department, so I mentioned a bit the guidelines that we circulated outside the department, but also within the department, we generated our own guidelines on, there's no one size fits all. So we really had to rapidly deploy telepsychiatry, as most US institutions did. And it was important to identify which consults will get what type of staffing, which was never present pre-pandemic. We used to see everyone in person, if not the same day, then the next day. And so the purpose was to maintain a rapid and high quality and efficient consultation service, to liaise with everyone, but also to minimize unnecessary exposure to the CL providers to COVID-19 and to conserve PPE, which we were running short on. Next, please. So we looked at the next slide, please. So we looked at the ACLP guidelines at what most US institutions had done and replicated what was feasible in our hospital. So several institutions had installed an e-consult process. So it was a chart review process where they would decide with the primary team on what was the best way to see these patients. So this appendix is what was circulated among colleagues and among residents on how to decide on which consults get telepsychiatry. So they could look them up by consult question, which consults needed curbside, whether it was like just a simple medication management consult, and which ones needed in-person. We've had a couple of in-person consults, especially if they require capacity consults and suicidal ideations, and suspected the psychiatric emergencies. But the modality, what is important here is that the modality of evaluation was always agreed upon with the primary team. And these again were taken somewhat from and modified from the ACLP website. Next slide, please. So how did we leverage telehealth? Again, as I mentioned, most institutions had done like a chart review consultative e-consult process. The telehealth model really was not very successful. If I want to talk about our successes and what worked, what didn't work, the telehealth model works best in high resource institutions. We struggled with the actual modality. So we put in a workflow, we put in place a workflow where the consult is placed by request online or paging or a phone call. And you start with the curbside. A curbside consult would still require documentation. Obviously, everything was documented. The discussion was initiated about whether we needed in-person treatment or not with the primary team. And if the primary team felt in-person assessment should be made, then the CL attending would go alone, just so that usually the resident goes first or the medical student, and then the attending staffs the case. We decided that in case there were a patient needed to be seen, the CL attending would do the consult alone. Collateral history and chart review and speaking with the family would be done by the resident, so they would still be involved in the case. If the questions were not could be answered by e-consult or curbside, e-consult meaning with a chart review, the CL resident discussed the case with the CL attending, and then the recommendations are communicated back to the primary team, but there was a daily follow-up. If the consult was best conducted via phone without a video, then it's done at the same time because there's an issue of scheduling it. So it was done at the same time by the resident and the attending on speakerphone, and it was documented. And if which we face difficulty with, if the consult was best conducted by video, or what we use usually within the institution is WebEx. Since patients do not have the families with them, we started facing difficulties because so most US institutions had implemented a tablet within infection that was cleared by infection control. We did not have that option. We suggested it was deemed not feasible because we were running low on resources. And most importantly, WebEx needs an email account. And so we faced a situation where the patient did not have an email. And there's this issue of confidentiality in that the easiest way would be to do a WhatsApp video call, but you cannot give the patient your number, in psychiatry especially. And so we tried communicating, setting it up with the resident's email or with the resident's phone. But residents on COVID unit are extremely busy. And so really they cannot stay for a psychiatry assessment, which would take a bit longer than the regular medical assessment. And so really it was not very successful as the telepsychiatry approach. We ended up doing mostly as things as chart review or going in to see the patients in the COVID unit. Next, please. The other thing we did on how to get creative, since we could not screen everyone and we could not see everyone physically, but it wasn't really fair to frontliners because they were basically covering every specialty. So we had one colleague that said, do you want me to also do the psych assessment? Because I just did the OBGYN exam on the patient, and he was an internal medicine resident. So we decided to circulate outside the department guidelines on managing, as I mentioned, the most classic consult question we see. So these are the bread and butter CL cases, the delirium, especially with agitation, and anxiety. I included these two images. They were taken with the permission. The first one is what the family of the patient. So we worked very closely with the families because remember, the frontliners are extremely busy. They might not have the time to communicate with the families as much as we could. And this is where our job as a liaison specialist comes in. And we educated them on the need to reorient the patient a lot because the most common cases were delirium cases. Early mobility, the importance of getting them out of bed, the importance of doing passive range of movement exercises, And this is an example of how these talking to the family works. So they frequently, every day, they change these signs to their mom. She was a COVID patient. To frequently reorient her, they would tell her where she is, what she had, that she needs to eat, that she needs to sit and stand. If you can read closely, I don't know if this is visible. And the next one, the one next to it, I think is very telling. It's a case of a 43-year-old patient who was who we were consulted on in the post-COVID unit for anxiety. Most of these patients had I forgot how to breathe anxiety. This is how the resident called it. It's like these patients forget how to breathe because they've been on the vent for so long. And as you would imagine, running as an internal medicine resident, running a busy COVID service, you really don't have the time to sit in and do the breathing exercises with the patients and address their anxieties. And these breathing exercises, diaphragmatic breathing and relaxation exercises, become extremely important when really the anxiety is around breathing. And so we had our health psychologist who was very active in this, but also our residents. Next. And we circulated protocols about this. Next, please. So not to be too dry, this is a crowded slide, but this is what was circulated on delirium. So we encouraged, if you start up, if you see the prevention part, we encouraged delirium prevention and screening. That cuts off the incidence of delirium just by doing that. If you look at the first box, it says it's behavioral changes that you can implement on the unit to the patient, and that cuts off the incidence of delirium by around 40%. And that was what the family was doing. So if you educate the family, they can do it if the nurses are too busy. And then looking for delirium, screening for it. And then once it develops, it was important to normalize the use of antipsychotics, which were usually medications that primary teams tend to avoid because I think there's an over-exaggeration of the risks of using antipsychotics. They're used for patients with delirium who are at risk of hurting themselves, including pulling out the oxygen mask, self-extubating, or those patients who are experiencing significant distress due to symptoms of delirium, even respiratory symptoms in the sense because they don't affect the respiratory, the breathing effort, the effort of breathing that one needs. So we put in, if you look at the sheet, we also took into account the change in polypharmacy of COVID-19. So if you're using azithromycin, which is an antibiotic that was commonly used on the COVID unit, you had to be mindful for the risk of QT prolongation, which is something that is not usually that severe, but with polypharmacy, it becomes a higher risk. We had included the first, just as an example of how we were able to adapt, the first draft of this included hydroxyquinone, but that was later let go of as a medication in COVID, in treating COVID, so we removed it. We also included, I'm not sure, we also included from the get-go, because these were patients we were trying to follow daily, but by providing these sheets, we might not actually get consulted on these patients. So we included, and I think that's important when you're providing sheets on how to start medications, to include a statement on how to get these patients off medications. So because the general, I think if someone has been doing consultations long enough, they'll notice that if you start the medications and don't put a tapering plan on how to wean off the medication, most likely the patient's going to be discharged home on it, including antipsychotics. So next slide, please. So we put in a taper plan on how to start, but also how to stop antipsychotics and benzodiazepines. We also did encourage them to consult us. I'm sorry, the font is very small here. So we did encourage them to consult us as well. Next, please. For anxiety, we divided based on, this is really based on the ACLP website, and we divided them by different types of anxiety. And again, a rule of thumb on medication management, what you use as medication is depending where the patient is and depending on what is available. So we modified it to what is feasible within our institution, meaning at AUB, you can't give IV Haldol, which is relatively safe. It's not that, I mean, at the dosages we give it, it's relatively safe, but by protocol, you cannot give it on patients that are not monitored, that are not on telemetry. And so despite Haldol being, IV Haldol being used very commonly in the States in their spreadsheets and their sheets and their protocols for management of anxiety, we removed it from ours because we really were focusing on non-critical care unit management. We had never done something of the sort, I think, before now. Dr. Talia, if you can correct me. But in terms of really, these are really our bread and butter, and we were just telling people how to manage without us. But I think that comes at a risk as well. Next, please. Clinically, we also had to get creative because COVID, anyone will tell you COVID presented differently in every aspect. We noted emerging themes, meaning new presentations in COVID and in the post-COVID patients. Post-COVID patients were admitted in AUB. They had their own, so we had a COVID building, but we also had a post-COVID ward where people that were no longer infectious with acute or post-acute COVID, meaning that they had been cleared for the past at least 4 weeks, so 4 to 12 weeks, that was it from the onset of symptoms, were admitted. The mean length of stay on the unit was around a month. A third of these patients passed away, unfortunately. So we conducted a chart review, and that was based, and this is where the importance of trainees comes in, that was really based on what the trainees had observed. And we decided to conduct a chart review on how COVID presented differently, because so much was being written out there on how COVID, the acute infection, affects the presentation, but very little was being written about how post-COVID, after someone's PCR was negative, how they would still present with, the consultations were still different than the pre-pandemic. Next, please. So these are the results of our chart review. So delirium obviously was the most prevalent. This is replicated in all international studies. Delirium, remember, is a medical condition. So obviously these have comorbid medical illnesses, and these are medically ill patients. So obviously delirium would be the most prevalent. It's important to keep in mind that delirium duration is a predictor of mortality, of in-hospital mortality. One study actually reported that a quarter of patients, of COVID patients admitted, died in hospital with a week within the onset of delirium. So it was important. So it's important to. This is why screening for delirium or preventing delirium becomes very important, and this is why circulating protocols across units becomes important. It's important to screen for it, to treat it aggressively, and even if it doesn't resolve completely, to at least shorten its duration. Non-responsive delirium, we were seeing more non-responsive delirium. So delirium was seen in around, I think, 31% of our cases, of our consults. Non-responsive delirium, this is very relevant in this context, because most of our consults for agitation would be, please come help us extubate the patient. So helping the primary team with extubation, because they would get agitated the minute you would extubate them, or the minute you would decrease the sedation on them. We tended to use, Dr. Talia knows that I'm a big fan of Depakote. So there is some evidence for using valproate in agitated delirium that is not responding to antipsychotics. Remember, the goal is to treat aggressively. And so if it's not responding to the first antipsychotic, you might want to switch immediately to BPA if it's a very hyperactive delirium. Next, please. This is important. So I'm not sure it's very visible in the table, but if you look at it, the day to psychiatry consult, so these patients stayed for a month. We were consulted around 2 weeks into their stay on the post-COVID unit, so that was a bit late. The reason for a consult is suicidality was only detected in around 8%, I want to say, yes, 8% of patients that we were consulted on. And when we did the actual evaluation, 38%, even those that were not depressed, had suicidal ideation. There's actually, early on in the pandemic, there was a report of a completed suicide in the US on a COVID ward. I think this is important because non-psychiatrists tend to overemphasize the risk of medications and underestimate the risk of agitation and psychiatric illness. So we were consulted late, and suicide was missed, so that was a high-risk situation. And I'll say this is despite having implemented at AUBMC a behavioral high-risk screening on all admitted patients. So even with the screening, the suicidality was missed. And it's thought to be that in the post-COVID syndrome, because of the cytokine storm that occurs, the actual inflammatory damage to the brain, that patients, the suicidality increases in these patients, not because of the actual depression or anxiety, but because of the neuroinflammatory changes. But this is just a hypothesis. So always screen for suicidal ideations in post-COVID patients, even those that are non-depressed. Next, please. What other different new findings where we've had to get creative as well. So close to 4% of our consults were serotonin syndrome, missed serotonin syndrome. Serotonin syndrome is a case of high serotonin levels in the body that can lead to acute kidney injury, high fever, that can be potentially lethal to patients. And missing them is a big risk to patients. And I think this is in part due to the polypharmacy, but also in part possibly because COVID might be a hyperserotonergic state. There are reports that platelets are coated with serotonin and are potentially hyperactivated in individuals with COVID. This is how we have more clots and more strokes, particularly in those with diarrhea. And remember, there's a polypharmacy that went along in all COVID patients. So these were on serotonergic agents because they were on a combination of pain medications, they were on a combination of antibiotics, they were on a broad coverage of every symptom possible. And so we have to look closer in when we're consulted for agitation, for physical symptoms of a hyperserotonergic state. We saw it more often. I want to mention this. I did 4 years of residency. I think during 4 years of residency, I saw 2 cases of serotonin syndrome. So the residents were actually the ones that started noticing these symptoms and doing the physical exam on agitated patients, instead of just assuming it's agitated delirium, which can look very well like serotonin syndrome. Very much so. And COVID-19, yes. And the last thing I'll say about clinical presentations that are different is the I forgot how to breathe panic that was compounded on actual respiratory symptoms. So as I mentioned, we had a bigger role for our health psychologists in non-delirious anxiety. We implemented the Hopkins physical therapy, diaphragmatic breathing exercise. One thing about this pandemic is that resources were openly shared, which I think should be the norm in medicine. But we really, resources were readily available. Everyone was sharing their own experiences, their own best practices. And it was really a collaborative effort globally. And medications used were very low dose antipsychotics because benzodiazepines make it more difficult, make the breathing effort more difficult. Next, please. Almost done, I think. L is for meta. So this is actually meta liaison. So if consultation liaison, the second part of our job is the liaison part, meaning we have to liaise usually between the patient and their primary team, especially between families and their primary team. And we tend to psychoeducate families, moderate the conversations. And this is a term coined by one of the ACLP prominent members, Dr. Juremovic, and he highlights the need that more than ever that there's a need during the pandemic to liaise with not just other departments, but also on an administration level to care for healthcare workers. So it's not just that the target is our patient, but the target should be also the healthcare worker. Dr. Talia has been very involved in healthcare worker mental well-being and burnout. And we actually conducted a study between April and May 2020, so 2 months into the pandemic. That was before the blast, early low numbers relatively of COVID. And we sent out surveys to everyone of the MDs, including fellows, attendings, residents, and the registered nurses that we have at AUBMC. And to look at their levels of distress, and surprisingly, 60% were at high risk of acute distress. And the IES, which is a scale that looks for the risk of post-traumatic stress disorder, was concerning for around a third of our participants, particularly the nurses and those that had at home were living with elderly or vulnerable individuals. Importantly, having a mental health history, which you can capture in our system because of the HIP system, but having a mental health history did not increase the risk of being at risk of distress during this particular pandemic. So really, you should assume everyone is at risk of distress from the healthcare worker. And this is where the role of the MENA liaison comes in. I want to mention, as I mentioned early on, the psychiatry department leadership had early on preempted this, and we launched the mental health first aid support groups for healthcare workers. So there were groups they could attend regularly, and there was a whole team of psychologists and psychiatrists that were dedicated for this. Next, please. The nice part about being in an academic center, which got tricky with COVID, is that you have training implications and you have research implications. So these are two things that were part of this momentum. And there's a whole, if you think about it, so this is a picture taken by Dr. Talia, actually. This is Michelle, one of our residents. And these are the medical students behind her. And if you think about it, so psychiatry training is 4 years. There's a whole generation of future psychiatrists whose training has been so affected by this pandemic. That's 2 years out of 4 years, 2 years so far. The pandemic is still ongoing, of a 4-year training that, yeah, it's the way the AIDS epidemic took over, I think the 80s, I'm not sure. But likely this will be one of those conditions where later on in life, the way we talk about patients having a history of cardiac disease or diabetes, or a history of going through cancer, we will at some point mention that this patient had a history of COVID-related hospitalization in 2020. So it will be one of those conditions. But also as a psychiatrist, these are trainees, learning has been modified. I don't want to say lost or gained, but just changed. So when you're talking to a patient, you're wearing a mask, or you're seeing a patient via a screen. There are components to the mental status exam, which is the psychiatry physical exam, that you immediately lose. And if we discuss the way the patient is walking into the office, the way the patient is maintaining eye contact, the way the patient is whether the patient is agitated or not, hygiene. There are components that are very important as a psychiatrist to notice. And it might be even if you're wearing a mask the whole time, even if you're seeing them inpatient. And so I think it becomes much harder to establish a therapeutic rapport. I was just talking to a colleague of mine who is in Toronto, and she said that she's a CL psychiatrist, but for the past 2 years, she's been really working from her kitchen. So the learning experience is changing. And remember that trainees, I put in this deliberately, trainees as colleagues, because you are learning with them. So you want to embed them in the response. They become really key in psychoeducating nurses on other floors and critical care teams on behavioral management of the delirium. We have a resident that always says, and is notorious now about saying, restraints are the enemy. And we are reading and appraising the emerging literature together. So you don't know much more than the residents do at this point in terms of COVID and COVID polypharmacy and everything related to COVID. So you are learning to them. So it's better to be open to their suggestions. And I think it's a lesson in humility where we get to learn with the residents, and they force you to learn because you have to start giving talks that are related to COVID. So be open to learning with them. Next, please. And lastly, the thinking outside the box in terms of research implication. It's true we are appraising the literature, but we are also creating the literature. I think this is a tricky time in medicine, but it's also at a time when we learn things from observations. I think this is a once in a generation opportunity. I was not very big on research, Dr. Talia knows this, but I think I got a promotion just from COVID literature, from writing up on COVID cases. You can make a whole career out of COVID psychiatry. So encourage trainees to write up the anecdotal observations. As I mentioned, this is our latest post. I think this was a chart review. This was written by two residents, Samer and Hida, who are really very keen on their observations on the COVID patients. They were reading up the literature, and they forced you to stay up to date. And this will likely be researched for another few years, so you might as well want to research it as if you want to be part of the momentum. Next, please. Long haulers are and COVID brain are receiving a lot of attention. I think you can get disability now in the States for if you're a long hauler. The definition is still vague. I think it's anyone with residual post-COVID symptoms. In our chart review, one of the patients required stimulants for the management of what was described as post-COVID brain fog or fatigue. Cognitive changes, poor concentrations. And so we might want to start screening for these in our post-COVID outpatient CL service. So COVID is likely going to stay for a few years. We just received the psych consult Monday on a COVID delirium in a 77-year-old lady. So this Monday. So it's far from being over. So we have to really learn from this pandemic. Next, please. What were challenges to delivering CLP care? Again, this is a bit redundant, but I'll mention it. So you have a dual objective. You want to maintain coverage as close to original setup as possible, but you also want to be flexible. You want to get creative. You want to address the massive shift in patient population within the system. It's a changing population. We're dealing with something completely different. You want to identify neuropsychiatric and psychiatric sequelae and formulate treatment approaches within the constraints from medication interactions to medication shortages, especially in Lebanon. You want to protect the healthcare workers. You don't want to be a vector of the illness itself to carry it home to your loved ones. You want to be a resource to the institution, to the department as a CL psychiatrist, to the institution, to the department, possibly to the community, while maintaining GME, ensuring the safety of graduate medical education and training, and maintaining research and academic work. So it's a lot of new challenges, and we have a lot of skills to still develop. Next, please. I've noticed that I've had to learn much more about extubation medications and critical care medicine because at some point the residents started knowing more than I do, and that was that was embarrassing. And so we have to learn to care for psychiatric patients that are in isolation. We have to support families of patients with illness or disease who are diseased from the illness, support quarantined individuals and groups, support healthcare personnel that are facing maybe a moral injury that came along with the pandemic and with the way care was provided during the pandemic. But we also have to learn from it and develop active contingency plan for when the next pandemic, because there will be a next one, when the next one comes. Next, please. I think I'm done. This is our beautiful view. So when you work in CL at AUB, you have to cross this bridge every day, and these are the perks of it, because you have, this is the bridge that we cross to get to the main hospital where we see patients. And thank you, I'm done. I think by the more side, these are the references. Next, and this is the view of this wonderful institution. Dr. Talia.
Thank you for sharing these nice pictures, but thank you really for this excellent and comprehensive presentation describing how to deal with the mental health impact of the pandemic in hospital setting. Really, the work that was done with your team and which you spearheaded is very impressive, and I think it should be more fully described in publications and papers, and to be shared with others, especially in the settings which we had, which we cannot forget. We were functioning in Lebanon in exceptional times, which are still ongoing. So there are very limited resources on the individual and national level. So again, I think this adds to the importance of the work that was done in extraordinary circumstances. So thank you for this presentation. There is a question, I will read it. So if you could comment on your experience with the medical students, even those in the preclinical years. I am head of the Student Affairs Office, not a mental health professional. I know that a large percentage of the students sought counseling during the last year. This created stress on the system, but also had one positive outcome, that students became more comfortable with recognizing and seeking help for emotional issues. So if you can maybe comment maybe on the general mental health of students, I guess the ones we see through the AUB system.
So I think, well, partly Dr. Talia is the, mentioned Dr. Talia is the clerkship director for our medical students in psychiatry. And he's had to get creative as well, because students really were both at risk, but their medical education was also at risk. They lost 2 years in their clinical years, and your clinical years are only 2 years. So basically, there's a generation of medical students that only saw COVID for that graduated, having seen only in the past 2 years COVID cases. We did do a survey early on in the pandemic on undergraduate undergraduate students, because they were really going through unprecedented times. These were students that were going in undergrad. Remember, in Lebanon, there was the October 2019 revolution. They were going through our banking system, our economic system collapsed. They were facing financial difficulty paying their tuition. They had no job prospects when they graduated. The uncertainty causes a lot of anxiety. They had switched modalities completely to an online learning experience without any preparation. So that again causes, and there was the COVID, the fear of being a vector, of getting COVID, of their loved ones being infected. And we saw a high rate of, if I remember, the results were similar to the ones in healthcare worker. We saw a high rate of distress, but we also of being at risk of acute distress, but we also saw a high rate of perceived stress that was correlated with the level of perceived stress. So I think if we normalize, if we provide preemptively, Dr. Talia, if you agree, but if we provide preemptively counseling to these, if we screen for it, if we provide preemptively counseling to these students and decrease their levels of perceived stress, we might actually decrease the risks of developing psychiatric conditions.
Yeah, I think this is a good idea, and putting it in a larger context of people being isolated, being young, maybe more access to substance use, smoking cannabis, drinking alcohol more in an isolated setting, which could become problematic. So they're isolated from their families also. So definitely, using the momentum to increase awareness and access to mental health is, especially among young people who are vulnerable, is a great idea. So thank you for the question. I have a question until we get other questions. Do you feel that initially starting this work, you and some of the team members and maybe even the medical students working with us, how did you manage COVID anxiety, the fear that the team members might get anxiety or having to be in contact? If you remember, we had to vacate our old building because of proximity to COVID patients, similar to HIV hysteria, maybe in the 80s, where people were afraid of this mysterious disease. How did you guys deal with that?
I faced it. I don't know if you remember, Dr. Talia, but early on in the pandemic, I developed the flu, which was, I never developed the flu, and I was COVID negative, and I kept doing PCRs for a week because I was, it was more COVID until proven otherwise for me, and the PCR detection rate was so low at that point. So much data was coming out there, and I have a vulnerable person at home that I risk being a vector. And if you remember, we've had these discussions, Dr. Talia, about whether we should cut down our presence in the department on hospital premises. So maybe one psychiatrist covering for all psychiatrists. And if you look at what the ACLP forum discussions were, there's no right answer for this because everyone was facing the same difficulties. And I find it shocking that in a moment of panic, everyone starts sharing experiences and collaborating. And what are you doing in your institution? Maybe you can do that in our institution. I mean, and when the pandemic resolves, everyone goes back to their own turf. I think it's important to keep that.
So COVID anxiety was a big deal, I think, that people dealt with. Our own fears to face this potentially and even lethal disease, and especially that outcomes were very random in the beginning. Very good. Anyone has any other questions? I have, again, one last question from me. I saw that you recently published a paper about COVID and the brain. Can you give us a very brief summary? What were some of the interesting findings? How can COVID damage the brain?
Yeah, so it was more on pathophysiology, but really it was describing all the evidence that is out there, because so much is being written and so much is being published with less, I would say less auditing, more easily published and then retracted. We saw that happen with some of the prominent journals. And so we reviewed the summary of evidence on the pathophysiology of how COVID affects the central nervous system. And partly there's a direct damage from actually damaging receptors, ACE inhibitory receptors, but there's indirect damage that is related to the cytokine storm, neuroimmunology, neuroinflammation, and I think, which is the part that I contributed to, I think partly as well with the mini strokes that we're seeing that might not be visible, there might be some vascular damage due to a hyperserotonergic state, which could be due to COVID itself, but maybe also the polypharmacy that we're using with COVID.
So like you mentioned, Jan, we cannot discount the mental health aspect of COVID and explain it completely by fear of the disease or anxiety. There are possible brain-changing interactions which can probably worsen any pre-existing or maybe even create a mental health problem.
Thank you. Thank you, everyone.
Okay. So I'd like to thank the organizers and Dr. Bizri and all the participants. Thank you.